All right, everybody, welcome back to our hospital medicine point of care ultrasound course. This is lung ultrasound part 4, the final chapter. Hopefully you've seen part 1, 2, and 3. If you haven't, or if you'd like to review them again, you can always go back to my website at proceduralist.org. And once again, I'm Jason Williams. Thanks for joining us today. So just as a quick recap of where we've been, we started with A lines and B lines, which is the most common application for point-of-care ultrasound on the hospitalist's day-to-day life because it really adds to your volume status assessment and CHF management. Then we talked about 4 other pathologies that ultrasound really adds a lot of sensitivity to that chest x-rays frequently miss, such as pneumonia, atelectasis, pleural effusion, and pneumothorax. Now finally in part 4, I wanted to go over some diagnostic cases in which we review those 4 pathologies. Specifically, I want to work on clinical integration today and make sure that you feel comfortable using ultrasound and incorporating it into your clinical decision making in these real life cases. So I recommend a systematic ultrasound evaluation for all patients with shortness of breath. Even though we're just focused on lung ultrasounds, you really should ultrasound other organs. And there's a lot of popular protocols out there like the Blue protocol or the CLUE protocol, the Pearls exam. They all do the same thing. They're thoughtful and they're systematic, and they increase diagnostic accuracy. For instance, you can just look at the lungs, and someone that comes in short of breath with an A-line profile often has COPD exacerbation. Could be other things like PE as well. If you have bilateral B lines when you come into shortness of breath, that's very consistent with CHF. And someone with an asymmetric profile with B lines on one side and A lines on the other, that's often a pneumonia. But when you start to add additional organ systems, for instance, if you see reduced ejection fraction, dilated inferior vena cava, and B lines, this really starts to support your exam for CHF as the diagnosis. When you start to look at things other than the lungs, including IVC and heart, can really add to your exam, as well as DVT, and you can pick up PEs if someone has an A-line profile and a positive DVT scan. So always think about the clinical context for your patient and decide which organs you need to ultrasound to add to your diagnostic accuracy. Let's start with the case here. This is a 45-year-old complaining of shortness of breath. Came in for acute renal failure and had some uremic confusion and somnolence. So the resident decided to place a central line in the right IJ, failed on the first attempt, so then tried the left IJ, couldn't thread the wire either time, and decided to abort the procedure. Post-procedure, the patient was hypoxic and short of breath and appeared to be in distress. So they performed lung ultrasound. Here with our linear probe, when we use the linear probe, you'll recall we're looking at the pleural line and trying to decide is there lung sliding or not. When you look at the left and right, is there any difference in the pleural line? So the left lung demonstrates some shimmering or lung sliding, and the right lung shows a loss of lung sliding. But it's not clear. The other thing is this pleural line tends to be fuzzy, or this one's a little more crisp. This is also consistent with a loss of lung sliding. But if you're not sure, do we have an additional tool to help confirm this loss of lung sliding? We can use M mode. If you place M mode over the pleural line, you can see here there's no granular beach. You got waves and you've lost the beach. This helps confirm that you do have a loss of lung sliding, and this patient's very high risk for having a pneumothorax after this procedure. So the Society of Hospital Medicine recommends before and after thoracentesis and central line, doing a lung ultrasound exam with the linear probe to check before the procedure just to make sure there's lung sliding, and then check after the procedure to make sure that lung sliding is still present. I do recommend checking before and after because you'll recall that the loss of lung sliding has a lot of false positives. You can look like a loss of lung sliding but not be pneumothorax. So it's important to see what the patient looks like as a control fashion. Before we start poking around the thoracic cavity, they may have severe bolus emphysema and as a result have very poor lung sliding to begin with. And if you know that before the procedure, you'll be more reassured when you ultrasound them after the procedure that you haven't caused this loss of lung sliding. So really scan before and after with the linear probe for thoracentesis and central lines to monitor for pneumothorax. What about this same patient following the central venous catheter placement and shortness of breath? If you got this chest x-ray, what would you be thinking in this case? looks different than that tension pneumothorax we had earlier. So when you place an ultrasound probe on this patient, now we're using the phased array probe in the mid-axillary line down by the diaphragm. You see liver, you see diaphragm, and spine here. And above the diaphragm, it looks like there's more liver or hepatization of the lung. This is a consolidated lung. Again, you can see the spine here because the ultrasound waves are traveling through the consolidated lung, hitting the spine and bouncing back. This is a very abnormal finding. What could be causing this consolidated lung in a patient that just had a central line? It was somnolent and uremic. So consolidation means a loss of air in the alveoli. That could either be due to pneumonia due to filling from purulent material in the alveoli, it could be due to compression from a large pleural effusion, or it could be due to absorption secondary to airway obstruction. So if you recall, this patient had uremic pericarditis. They were confused. They ended up aspirating a mucus plug into their right mainstem bronchus. As a result, this lung completely collapsed as the air got reabsorbed, and you can see the mediastinum has actually shifted this direction. So this consolidation is due to the lung getting squished due to reabsorption from mucus plugging. The other things that can cause this pattern would be a peripheral tumor. Tumors can obstruct the airway and cause reabsorption, as well as if you accidentally intubate the right mainstem bronchus, you can cause reabsorption in the left lung since you're not ventilating that lung. What about this patient after their central venous catheter replacement? We have another whiteout here on the chest x-ray. What could be causing this? So again, whenever you have a whiteout on chest x-ray, ultrasound can help you clarify what is that white material. So here again, we're in the mid-axillary line on the right side. We see liver, diaphragm, and above the diaphragm, we have another spine sign. That means we're transmitting sound waves through a fluid medium, hitting the spine and bouncing back. If you have normal aerated lung, those sound waves are scattered and they never return back to the probe. But instead, we have something conducting sound waves very well, which in this case is a hemothorax or pleural effusion. You see another consolidation pattern here, and this is due to compression from the pleural effusion. You can see there's a large pleural effusion that's slightly squishing the lung. But in this case, following a central line, we'd be very worried about a hemothorax. All right, let's move on to a different scenario. This is an 85-year-old with mild dementia, pending rehab placement. The day of transfer, he says, I have some congestion, and 1 hour prior to transport to his rehab center, he also notes some cough and purulent sputum production and left pleuritic flank pain. He is a little tachycardic and had new hypoxia, and there's no breath sounds on the right side of his chest. 9 days prior, he did have a chest x-ray that had some chronic left diaphragmatic elevation, but it was a relatively clear chest x-ray other than that. So we placed an ultrasound probe on this patient, and what do we see? So here's liver. We see spine. Again, we have spine sign, which means we're conducting sound waves through some type of fluid here in the thoracic cavity. You also start to see some loculations popping up as well. The pulm was consulted prior to any formal imaging, just with our bedside ultrasound, and they saw this chest x-ray from 9 days prior, and they said, don't worry about it. It's just an elevated left diaphragm causing the decreased breath sounds. We don't recommend any further interventions. But I think when we're looking at this patient and he's got septations, cough, sputum production, and tachycardia, I'd be very worried about an empyema in this case. And I decided we should probably work this up a little bit further. So if you recall, septations or echogenic fluid are always an example of exudative pleural effusions, which should get a diagnostic thoracentesis to evaluate further. Particularly in this case, the question is, does he have empyema or cancer with septations? And since this chest x-ray was relatively clear 9 days prior, cancer would be very rapid to develop in 9 days. It's much more likely an empyema. And patients that have empyema with septations have longer lengths of stay, and they're more likely to need a TPA or surgical decortication to treat them. A chest tube alone is often not sufficient. So you can see here that on CT, they were able to see he's got trapped or tethered lung here up against the chest wall due to inflammation. And that's what we're seeing here, that this thick septation with a consolidation is actually lung that's stuck up to the chest wall due to all the inflammatory pus causing trapped lung. So the question is, where do we perform our thoracentesis? Now you can use CT to potentially help with this, but ultrasound is really key. So here's consolidated lung up against the pleura. You don't want to put your needle in this area. Versus these thin septations, this is just due to the pus and loculations. This you can put your needle through and not worry about poking these because it's not going to do any damage. You're just going to break up that fibrous, purulent material. Thin septations are a good thing. This echogenic consolidation you don't want to stick your needle into. This is a safe place for a thora, not safe. So after several days, this patient got a chest tube, confirmed that he had an empyema, and the CT that was non-contrast was performed and said there's just some residual inflammation and atelectasis without residual fluid collection. I wasn't so sure, so I decided let's put the ultrasound probe on this patient before we pull out the chest tube. CT surgery had recommended we pull out the chest tube based on that CT finding. But when we place the ultrasound here, we can see there's still a residual fluid collection. This black anechoic fluid is consistent with more purulent material that has yet to be drained. Because this patient wasn't given IV contrast, it's hard to delineate what is atelectasis and what is residual empyema. But with ultrasound, it's very clear. He needs more drainage of this pus, if at all possible. So after we convinced CT surgery there was residual pus in this that wasn't adequately drained by his chest tube, we initiated TPA and we got another 500 cc's of purulent material out of his chest prior to him returning home. Ultrasound is going to be superior often to even CT when it comes to characterizing your pleural fluid, especially in cases like this with empyema. All right, here's our next case. This is a 58-year-old male with hypertension and diabetes, complaining of some nausea, diarrhea, and weakness for the last 2 days. He does have a temperature of 100.5 degrees and tachycardic. His white blood cell count was normal, though there is a low lymphocyte count, and his rapid COVID was negative. And this is in the setting of our COVID epidemic. The chest x-ray was a little bit nebulous. It was read as a possible opacity in the right upper lung fields. So the question that we were asked is, can we admit this patient to a regular floor bed, or do they have to go into a special COVID team and special COVID isolation unit? So I suggested, why don't we clarify what's going on in his lungs with ultrasound to see if that can shift our pretest probability of COVID in this patient. Because he does have a rapid COVID, but we know the sensitivity of these rapid COVIDs could be as low as 80%. So maybe there's a 1 out of 5 chance he truly has COVID and needs that isolation. So his anterior and lateral lung zones had A lines, but when we got to the right lower, left lower lobe, we start to see some B lines pop up here. And furthermore, you'll notice the left side has a nice linear pleural line. It's uninterrupted. But over here, there's a little bit of irregularity right here in the pleural line. And a B line arises from that irregularity. This irregular pleural line suggests this is not just fluid, but an inflammatory infiltrate, causing this irregular pleural line. Could this be CHF potentially? Because CHF can have bilateral B lines in the lower lobes. His CVP was 3 on his inferior vena cava ultrasound, and he had a hyperdynamic ejection fraction, which you often see with sepsis. No signs of CHF from his inferior vena cava perspective or his cardiac function perspective. So with this irregular pleural line, this small subpleural consolidation, bilateral B lines, we had a high suspicion for COVID pneumonia. So how do you diagnose pneumonia with lung ultrasound? The easy way is if you see asymmetric B lines, subpleural consolidations, or larger lobar consolidations. But there's some issues here because sometimes pneumonias can have less than 3 B lines. In this case, I think this patient only had 2 B lines in one of those lung zones, and it can be symmetric, which COVID often is. So you really have to put this into the clinical context, where looking at the IVC and cardiac function as well as his leg exam can help you evaluate for CHF, and knowing that he has a fever in the setting of COVID with bilateral B lines really increases the likelihood this could be COVID. So those subpleural consolidations are much more specific for pneumonia. In patients hospitalized with COVID, B lines are more than 90% sensitive for COVID pneumonia. The most common location is in the bilateral lower lobes. So we'd like to think that pneumonia is asymmetric, which it often is, but COVID can often be bilateral, and many viral and bacterial pneumonias can be bilateral as well. In subpleural consolidations, we're seeing about 30% of the time in patients hospitalized with COVID, and that can increase the specificity for those findings. All right, so let's summarize. I really encourage you to get the linear probe and do a lung sliding exam pre and post thoracentesis and central lines. It'll really aid in your detection of potential iatrogenic pneumothorax. Anytime you have a whiteout on chest x-ray, it can always be better clarified by ultrasound and trying to figure out, is this consolidation, is this a pleural effusion, or is this something else going on in the lung? Remember, there's a differential for consolidation, and it could be compression, reabsorption, or pneumonia. An ultrasound is quite superior to CT for characterizing pleural effusions and recognizing exudative ones that need further workup and management. Pneumonia, it's hard to diagnose with ultrasound. B-lines can be nonspecific, so you really got to add some clinical integration. And if you see subpleural consolidations, it does increase the likelihood that you're looking at pneumonia. So try to look for those closely if you have a suspicion for pneumonia, such as this subpleural consolidation you see here, popping up on the pleural line. All right, that's it for our lung ultrasound course for hospital medicine. Thank you for joining me. And if you'd like to return to our website at proceduralist.org, there's a set of quizzes that you can review to get further practice in recognizing pathology and doing clinical integration of lung ultrasound. Thank you and take care.